Thank you, friends, for sparing your valuable time on this Sunday evening. It truly is a session on innovations in lifestyle diseases, and we were just listening to Mr. Modi's journey through the innovations that he could do in this area of non-communicable diseases. To put it in Archimedes' words, give me a fulcrum and I shall move the world. Such was the vision of this man, and one can be very proud of the fact that this country has initiated this practice of fixed dose formulations, although we find it a little odd at times. But I would say India has taken the lead in fixed dose formulations all across the world. And when it comes to some diseases which are lifestyle diseases, which are requiring lifelong therapy, like diabetes, hypertension, coronary artery disease, the reduction of a pill burden of an individual becomes a very important and integral part of improving the compliance. Besides the way we interact with our patients, it improves compliance. And you know, compliance is a very key factor in terms of reduction of mortality when we look at how much impact the best thought of drug therapy that you decide, how well that patient is, how compliant that patient is. It is this what determines in terms of mortality reduction and in terms of morbidity reduction also, how much benefit your patients derive out of this. When we were formulating the Indian hypertension guidelines, at that time, way back in 2001, when we formulated the first guidelines, it was an issue because in India we were quite familiar with fixed dose combinations, whereas the Western world really discouraged fixed dose formulations. And I would say there is a big leap in this direction. There would be certain issues which are there in your and my mind. There are some kind of thoughts which comes to a mind of a physician that this is too simplistic a formulation that we have formed. But if you really look at in terms of real world life, sometimes you have to look at things that are practical and not things that are ideal. And in that sense, this is a very practical way of improving compliance of patients. And I would share in the next 10-15 minutes how this process of improving the quality of life by redefining disorders, it improves treatment strategies, and of course it does translate into saving millions of lives, because importance is overshadowed by two things: the cost and complexities. And this is what we have to look at, especially in our country. We are actually talking of a disease which is the #1 killer of mankind. As you all know, cardiovascular diseases contribute 31% of mortality of mankind. The other non-communicable diseases all put together contribute about 33%, whereas communicable diseases today, this is the world data, not data from our own country. But even in our country, non-communicable diseases, as our longevity of life has increased, non-communicable diseases again contribute largely towards mortality as our people are living longer and longer. Today the longevity of life in this country is about 64 years. As we grow a society which has a longer longevity of life, Japanese have one of the longest longevity, 82 years. People in English have about 79 years. Americans have a longevity of life of about 78 years. So there's still a long way as a healthy nation that we have to go. And as longevity improves, these non-communicable diseases, our individuals get more often inflicted with these non-communicable diseases, and people will be affected more and more with this whole panorama of diabetes, hypertension, coronary artery disease, and cancers, of course. This is another non-communicable group of diseases. The InterHeart study was one of the largest studies. About 20,000 individuals were studied. And when the InterHeart study came about 10 years back, at that time people were looking at various risk factors for coronary artery disease. And it was believed at that time, people used to teach that there are 200 risk factors for coronary artery disease. Someone used to say there are 170 risk factors for coronary artery disease. Because very often we used to all see patients in our clinics who would come to us who would not have diabetes, who would not be smoking, they would not be obese, and they still would be having an acute myocardial infarction, and they would have no family members who were infected with this disease. And so often, many of you would have been asked these questions in public lectures, in Rotary clubs and otherwise, that I have none of these, why did I get infected? And this is what raised a feeling in the medical fraternity that possibly the WHO defined risk factors that we had, are they really able to explain to the extent why someone gets coronary artery disease? And at that time, this particular study, in which India participated very significantly, India, China, and in fact it was a study done across the globe in all the 8 continents. What was found was, now what they looked at is 9 risk factors, the conventional risk factors that were known to you and me: smoking, diabetes, hypertension, lipids, lipid abnormalities, obesity, whether people took high quantities of fruits and vegetables. And if you looked at these common risk factors, it could attribute 90% of the coronary artery disease. And ever since then, it is for this reason that our effort and endeavor to look at newer risk factors has stopped, because we today realize that these conventional risk factors, which are known to you and me in terms of obesity, sedentary lifestyle, hypertension, diabetes, smoking, they can explain almost 90% of the coronary artery disease. In some, one would be involved, and in another person, the other risk factor. Also, what this study showed us was the risk of myocardial infarction increases 26 times when 8+1, age being the kind of manageable risk factor. When you are beyond 55 years of age, your risk doubles. But all other are modifiable risk factors. And this study did tell us that if we can hit at all of these risk factors, we can possibly reduce, in terms of primary prevention, the occurrence of these events, and even in secondary prevention, if we can manage all these risk factors effectively, we will be able to make our patients live longer. So the InterHeart study did show us that to a very large extent, these 8 modifiable and 1 non-modifiable risk factors were responsible. Also, the PURE study showed us that majority of the people are on antiplatelets, beta blockers, ACE inhibitors, and statins. And the real issue was of compliance, which is the factor whenever we look at real life medicine. The figures are rather startling. And if you look at this PURE study data, what we find is in high income groups, the low middle class, the high middle class, the low middle class, and the low income groups, whether people are living in the urban areas or in the rural areas, at best the compliance is about 60%, which drops when you are looking at a large percentage of our population. Whenever you have to visualize the Polycap, you have to really look at the real world scenario in our country as to what situation our patients are in, what levels of compliance our patients would achieve. You can make out the figures are rather dismal, and this most of us do see. It has been shown in this evidence-based trial also. Even in the Western countries, the compliance of some of these 4 agents that are so beautifully known to us to reduce mortality, when it comes to, we know when we reduce blood pressure and we bring blood pressure to normal levels of 140/90, we are able to reduce the risk of coronary artery disease by about 20 to 25%. The stroke risk is reduced by about 30%. Similarly, when you treat dyslipidemias effectively, you reduce risk of coronary artery disease by another 20 to 25%, and stroke rates are reduced by 35 to 40%. Not many years back, people used to believe dyslipidemias are not responsible so much for strokes. It was felt that it's hypertension which is responsible for strokes, whereas it is dyslipidemia which is responsible for coronary artery disease. But we know essentially the process of atherosclerosis is the same. Although blood pressure is a bigger risk factor for stroke occurrence, and dyslipidemia is a bigger risk factor for coronary artery disease occurrence. Similarly, platelet aggregability, increased platelet aggregability, if you treat it, you are more effectively reducing mortality by about 30% in terms of coronary artery disease and 20 to 25% in terms of stroke. And thus, it has been realized that when you reduce blood pressure effectively, if there is a 10% reduction in mortality and you reduce total lipids by about 10%, it doesn't add up to 20, but there is when you treat multiple risk factors effectively, the implications, the benefits are multiples, they are not additives. So you are able to reduce, this particular data is available for many hypertension HDFC trials also, where we have seen whenever we combine antihypertensive drugs with statins, the amount of mortality reduction that we achieve is much higher than when we hit at one particular risk factor. And therein lies this Dr. Salim Yusuf, who was the architect of some of these trials, which in our country we can be proud of, because some of these trials, the InterHeart study, we were participants in, and the CREATE study, which is our own study, which is quoted all over the world in terms of acute coronary syndrome. What about 20,000 patients again in this CREATE study. What Dr. Salim Yusuf's premise was, in this editorial he wrote before all this work was done, the relative risk reduction with aspirin is to the tune of 25%. The relative risk reduction when you use beta blockers is to the tune of another 25%. Lowering of lipids results in a risk reduction of about 30%. And we all know that whenever we use ACE inhibitors, as from the HOPE trial, whenever we use ACE inhibitors as primary preventive agents, we are able to reduce mortality by 25%, and the 2-year event rate in an individual with coronary artery disease decreases from 8% to 6% to 4.5% to 3% to 2.3. So when you are combining these 4 agents, because coronary artery disease is a disease which is multifactorial, it's not a disease which is due to one risk factor. Most individuals are harboring multiple risk factors, and those risk factors are not at peak. Don't expect, most people who get coronary artery disease have mild dyslipidemias, have mild hypertension, they are sedentary lifestyle to an extent. So whenever there is a conglomeration of these risk factors, and by the same premise you will have to hit at all these risk factors in case you want to reduce mortality, whether as a primary preventive or as a secondary preventive. This of course is data if you have to look at secondary preventive in individuals who have coronary artery disease. What would be the 2-year event rates in terms of its reduction? Dr. Nicholas Ward has similar, he believed that if you also combine folic acid, which affects serum homocysteine levels, although to date we do not have data which shows that homocysteine levels, when they are high, they correlate with the occurrence of coronary artery disease. But to date we have no data which shows if you reduce homocysteine levels by use of folic acid, multivitamins, whether it kind of translates into reduction of mortality. So we do not have data in terms of reduction of mortality, although correlation is there. People who have high homocysteine levels, they have higher occurrence of coronary artery disease. However, in this particular study also, in this particular editorial also, he felt that we could reduce this mortality to a very large extent. Compliance issue is of course a big issue, and it's been seen that 1/3 of patients who are put on a therapy after myocardial infarction, within a month, 1/3 of patients are no longer taking this form of therapy. In about 15% patients, they discontinue one medication. In about 15%, they discontinue all the medications. So the compliance issue is certainly a big issue, especially when you look at a disease which, and this reduction, this lack of compliance translates into survival reduction over a period of 12 months. When you look at individuals, how many would be surviving? Those who are non-compliant to this combination of 4 agents, of course, those who drop all 4 agents, their benefits are much less, and their survival rates are also significantly lesser, to a tune of about 10% lesser over a 1-year period when you compare them with individuals who are significantly compliant. And thus an innovative idea came in fact to Dr. Salim Yusuf's and Dr. Srinath Reddy's mind, who were the architects along with Mr. Modi in terms of looking at these trials in this very country so as to see what would be the reduction in mortality if we combine, we give a simplistic form of therapy to our patients who are rather illiterate, who are not very kind of compliant with drugs. And so this journey started in the protocols for the clinical trials were made in 2004, and in 2009 the TIPS1 study, which was an Indian study which was on the Polycap, of the architects of which were Dr. Salim Yusuf, Dr. Srinath Reddy, and this trial was done in many centers all across the country and was then published in Lancet. And thus this drug was launched in 2010, the Polycap was launched in the Indian market. Then subsequently the TIPS-2 clinical trial was done, which of course bagged the Wellcome Trust Award, and now the TIPS-3 across different countries has been done. So there is evidence-based medicine data in terms of when you combine. The fear has always been that you cannot just put drugs in a capsule and then expect that the drugs would act similarly, because the combination can affect one drug, can affect the metabolism of other, and that is where these trials so significantly allay your fears. Now the combination that is used in this capsule is 3 antihypertensive agents: hydrochlorothiazide, atenolol, ramipril, a lipid-lowering agent, simvastatin, and an antiplatelet drug, acetyl salicylic acid. Now we have evidence-based. There are issues if you look at, because as antihypertensive agents one can argue and feel that hydrochlorothiazide is no longer the best antihypertensive diuretic that we have. We all know chlorthalidone is a better diuretic to use. We also know we don't like to combine beta blockers and thiazide diuretics, because as a combination, new onset diabetes incidence increases. But these are possibly issues which affect only marginally. But when in terms of, we all know from the All-Hat study, when we reduce blood pressure significantly, the mortality reduction is largely dependent upon how much you are able to reduce blood pressure, not how you reduce the blood pressure. And also the cost issue is there. These drugs happen to be the cheapest ingredients of antihypertensive agents. So when this whole combination was tested in a randomized trial all across, it was seen that there were significant benefits. The drug interactions were not so significant in terms of effectiveness of these drugs was not lost. And if you look at, when this Polycap acetyl salicylic acid was compared with the baby aspirin, we know Altes is the brand which is used world over. When the ramipril was compared of Polycap with Altes, the Zocor we know is the brand of simvastatin, and tenormin of course has been a popular atenolol brand. So in terms of bioavailability, if you look at this trial, the bioavailability is maintained, and there were no significant pharmacokinetic interactions, which would be a fear in the mind of any clinician. And this was the reason it translated into greater benefits was 92% patients completed this trial. This is a very high percentage of patients completing, and the Polycap did preserve individual pharmacokinetic profiles. And so in this study, which was then published in Lancet in the year 2009, it did show that there was significantly better control of blood pressure with these 3 agents as compared to a single agent if it had been used. There was a reduction in heart rate, LDL levels were lower, platelet aggregation was less, and as I said, 85% patients completed this trial in the Polycap arm, although larger percentage did complete in the non-Polycap arm. Also, both groups showed reduction in LDL levels as was expected with the single use of simvastatin, and also the effect in terms of platelet aggregability was similar when these drugs were used in combination as against had they been used alone. In a subsequent TIPS-2 trial, which was published in Circulation Cardiovascular Quality and Outcomes, 518 patients with previous vascular disease, or this is a high-risk subset of patients were taken, and what was found was a single dose of Polycap was compared with a double dose. And we all know when we increase dosages of these agents, they become more effective. And we know from the HOPE trial, the effective dose of ramipril is 10 milligrams. And we also know simvastatin is half as effective as atorvastatin. So if you were giving 20 milligrams of simvastatin, you can say we were giving 10 milligrams of atorvastatin, or we were giving 5 milligrams of rosuvastatin. And we know it's the first 10 milligram dosage of atorvastatin, or 20 milligrams dosage of simvastatin, or 5 milligrams dosage of rosuvastatin, which results in 25% reduction in LDL levels. And every subsequent doubling of dosage that you would make would result in only 7% additive effect in terms of reduction of LDL. So that is the reason it is said that all your patients of coronary artery disease, all your high risk individuals should be put on lipid lowering agents at the baseline dose. You should not deny this agent, and also for this reason 20 milligrams of simvastatin today is an over-the-counter drug, because it does not need monitoring of liver enzymes or of CPK, because at this low dosages, although your benefits are relatively lesser, but still a large part of the benefit you are imparting to your patients. So you really need to see as to what your compliance level of your patient is. If you find your patient is compliant, you can use multiple drugs in appropriate dosages, but you have an agent available in your armamentarium today with which the compliance factor, and this has been tested in a randomized double-blind trial and has been published with evidence-based medicine. So this particular experience was, for the first time I would say, it was documented in a trial that when we combine these agents, the drug interactions are not very significant. Of course, when we will double the dosages, what would happen is the benefits would be in terms of coronary artery disease reduction on the right side. The benefits would be certainly greater, 69% as compared to 62%, and stroke rates would be reduced to a larger extent, 48%, 57% as against 48%. So the dosaging has to be dependent upon your patient's blood pressure levels and also your patient's tolerance levels. Now in this EMPIRE trial, it's a transnational trial in which about 1,000 patients have been taken from this country and 1,000 patients have been taken from Europe. And we realize in whether these patients are taking this poly pill in this country or in countries abroad, there is significant reduction, improvement in compliance. And thus these couple of trials, of which Salim Yusuf has been a very big proponent. Any CSI that you attend, there will be a discussion on polypill. Polypill is an Indian drug. Salim Yusuf is obsessed with this. Lot of cardiologists all across the country are not very happy with this because they feel you are binding a clinician's judgment in terms of using different dosages of the drugs. But this, what he propagates, is for individuals who are poor, for individuals who are non-compliant, for individuals who are not going to take drugs in a manner in which you and me as a physician would want, and we can at times judge who are our patients who are going to be compliant, who are the patients who are not going to be compliant. Even the European guidelines have today adjudged individuals without CVD demonstrated that the Polycap formulation could conveniently reduce multiple risk factors, and it also results in terms of improvement of compliance. The other recommendations do today recognize the evidence-based medicine today we have with fixed dose combination therapy, since it reduces the dosage demands. So I would say Polycap is an example of innovation that has been shown by evidence-based medicine. A lot of our practices that we make, we cannot talk in terms of science unless we prove it with an evidence-based, and here is a combination which I would say was designed by primarily Indian scientists. Of course, Salim Yusuf was an architect to this, but what we today find, it has been shown to be beneficial in terms of reduction of mortality in patients with coronary disease. There will be a subset of patients in any clinician's office who you will feel are more suitable to this particular combination, because multiple pills, lesser compliance, more inconvenience to the patient. And the clinical trials, of course, have shown that this particular combination does not affect the pharmacokinetic kinetics of the various components to a very large extent. Thank you very much for your patient hearing, and congratulations to Cadila for bringing this session to us. We can discuss. I'm sure that it's a very contentious issue. Any new thought initially will have a lot of inhibitions, but it's been shown on evidence-based medicine that it is effective. So we'd like to have comments. Dr. Dhar came a little late. We'd love to have your comments and anything.
Certainly after your very forceful and effective lecture, a message is conveyed that this combination is really a very wonderful one, and we must take pride that it has come from this country. I would like to add that fixed dose combination does not prevent us from adding any one or more component of either the same drug or of another drug which has the same effect, say antihypertensive or lipid lowering effect. That is the advantage of this. That way this product is really unique. It doesn't bind you to just you have to give one. But as Dr. Wander has effectively emphasized, that compliance is a very big issue in terms of those diseases which take long time to manifest, and coronary artery disease is one. So many of us sitting here must be having it, but we are still having a silent sort of disease. So this drug is really a great combination, and I must congratulate Salim Yusuf and all his team for this wonderful armamentarium in doctor's hands.
Thank you, sir.
Thank you, Dr. Wander, for a wonderful lecture. I think I never thought anybody could project and present this formulation in the way you have done it. Congratulations and wonderful lecture. And as you said, I think I means no words in saying that ever since its launch, I have been using this medicine, this combination, and I have had no complaints from any patient so far. And as you said, there regarding the pharmacokinetic compatibility, that's why it has been, that has been taken care of in this formulation, and that's why we find atenolol non-metoprolol. Because of the pharmacological compatibility in the same capsule, we find atenolol non-metoprolol. And again, not to emphasize again and again, in Indian scenario, and I am a simple physician, and that type of population I have been catering to with uneducated, illiterate villagers, low socioeconomic status patients. I think it's a wonderful combination which I have been using. Thank you.
Thank you, Karamveer. I think Karamveer will be the best person to look at, because he's shifted from a strata to a totally opposite strata now once he joins Fortis. So he will be treating all kinds of patients. And I'm sure even in this strata you will have lots of patients, because compliance is a character which is not only dependent upon cost issue. Compliance is a habit with a lot of us, and patients always feel one pill in the morning is better than multiple pills, which interferes with their work schedules. And as you beautifully said, the drug combination, when same drugs affecting on the same disease, multiple factors will of course be combined, it makes a difference. But as Sir said so beautifully, this particular capsule will not be for all the patients. In some you will use it in combination with others, because you might like to use Ramipril in 10 milligram dosages, you might like to use simvastatin in higher dosages. In some you might like to combine. In some it may not be applicable, especially in patients who are not that hypertensive, who are normotensive. So certainly as a physician, you need to know what is there in the combination and which are the patients who will be best suitable, as Dr. Karamveer and Dr. Dhar just said.
Good evening. Sir, thank you very much for a very informative talk. I have just two queries. One is that for TIPS and TIPS 1 and 2, they were structurally different trials. Number two is the issue of aspirin being 100 milligram, was it same dose in all the three trials, or has it ever been discussed to increase it to 150 milligram? Because in stroke, we really do have a issue of using 100 milligram instead of 150 milligram.
Yeah, I agree, Dr. Bansal, with you that over a long period of time, actually, the cardiologists use lesser dosages of aspirin, whereas in stroke prevention, you people use higher. Although I really don't know why this particular distinction is made, because it all essentially depends upon the effectiveness of antiplatelet effects of aspirin in terms of how effective it is. And it's been seen 50 milligrams, 100 milligrams, 150 milligrams. In fact, in acute coronary syndromes in unstable angina, when aspirin was first used in the first trial, it was used in almost 1200 milligram, 1200 to 1500 milligram dosages. And subsequently, the dosages have come down and down. And today we do not really have a if you look at the trials which were done in terms of effectiveness, the 50 milligrams, 100 milligrams and 150 milligrams makes no difference in terms of effectiveness of antiplatelets, and sadly does not even make a difference in terms of occurrence of GI side effects. Because a lot of us use lesser dosages thinking that these GI side, but GI side effects, especially erosive gastritis, GI bleeds, if it has to happen, it will happen with the lower dosages as frequently as with the higher dosages. So whatever dosage you use, it's not going to be very significant. In the West, if you see 80 milligram, 81 milligrams, for whatever reasons they know best, they use 81 milligrams, although in this country we use either 75 milligrams or 150 milligrams. It's an issue which I think makes some marginal difference, doesn't make too much of a difference, and somewhere they had to strike a compromise at the time when they are putting it into a combination. So possibly that is the reason. It is, as I said, a contentious issue, and there must have been lots of thoughts in terms of bioavailability which must have gone, because ultimately, see, what Salim Yusuf says is not accepted by lots of people, and that's why I did not say this. He says it's a mass pill for the masses, for primary prevention, which generates a lot of skepticism, doubt and fear, because to date, although we have data with statins as primary preventive agents, we know as primary preventive agents, statins make a significant difference, but less than as secondary preventive. Similarly, we know from the On Target, from the Hope and from so many other trials, that when these ACE inhibitors or to a lesser extent ARBs are used, they impact in patients who are high risk, especially diabetics who have peripheral vascular disease when you use these agents. We do not have data to date whether aspirin makes a difference as a primary preventive agent. In fact, in diabetes, which is considered as a coronary artery disease equivalent, for many years it was said that you use aspirin as a primary preventive. Even the American Diabetes Association latest guidelines have withdrawn aspirin as an agent to be used in all diabetics. No trial has shown in hypertensives, if you use aspirin as a blanket therapy, it makes any difference, and that's why no guideline across the world advocates use of aspirin for primary prevention. So there is an issue which we have to keep in mind. Certainly polypill is good for secondary prevention. This is my personal view. Although Salim Yusuf's view is, the reason he brought this was, he said let's distribute it to multiple people. So that is where the kind of acceptance of his concept is to a lesson. But people who are convinced, he must have been convinced, he's gone through the literature, he's done a kind of a multifactorial analysis of these things. But certainly as secondary preventive and in high risk individuals, this is my personal opinion, and so also as Dr. Dhar and I'm sure yours also, that it makes a difference when we combine. And I would say over and above, if somebody is hypertensive, then it possibly becomes an ideal kind of a combination, because you're effectively treating pressure also, reducing the lipids to an extent, using it as at a dosage which is not needing to monitor their liver enzymes or their CPK levels. So, thank you.